You all know how much we love ProCare. We talk about them all the time, pretty much in every episode we record.
Pretty much.
So we are really, really excited to announce.
They're sponsoring the podcast.
Yay!
Oh my goodness. I'm so excited.
Yes. And we truly believe in their product because we take them every single day. I take their 1-a-day capsule.
Yes. And I take their 1-a-day chewable. It's freaking delicious.
And not only do they have multivitamins, but they have calcium chews.
Yeah.
Delicious calcium chews. The salted caramel is to die for.
Oh, and the cinnamon roll, guys, tastes like a cinnamon roll. Oh my God.
They also have dinner mint, but our favorite
is the dark chocolate for 2 reasons. One, you can have it at nighttime for a treat or make a s'more out of it. We've done it. Freaking bomb.
How cool is that? So go now to procarenow.com and use code OSLP for 10% off.
Alrighty, now go now. What are you waiting for?
Go get your vitamins.
Yeah.
Guess what, guys?
We're not doctors.
No, we are not.
So if you're going to be making any major medical decisions, please consult your doctor.
That includes diets, surgeries, and exercise.
We love you guys.
And we want you to continue to be in our OSLP family forever.
So be careful and consult your doctor.
Yeah. Welcome back, OSLP family!
Welcome.
You are listening to our Sleeve Life podcast, and this is Kelly.
This is Mel.
And we're in Florida.
Yes, we are.
And we're back at the Duck Duck production studio.
Heck yeah, this is so much fun. I love their studio.
I know. We talk about it all the time.
We do.
We're like, oh, yeah, when we were in Florida, we got to go to Duck Duck.
We got to go to this professional studio.
Yeah.
Be jealous. No, just
Yeah. We're kind of famous. So we have Dr. Dovec in the building again. And we're in person.
We're in person.
We're not over Zoom.
I
Yay.
know. I have a fancy microphone.
Yes,
Ooh,
you
don't I
do.
sound so good?
I do.
It's a different sound when you're in person.
Oh, yeah.
Yeah.
I remember the first time we did Zoom. I'm going to squirrel for a moment.
Totally fine.
And I was like, Mel, I don't like the audio. And she's like, Kelly, that's just the way it is with Zoom. And I'm like, but can we fix it? I don't like it.
I know yours is professional. Mine sounds like I'm in a bathroom 10 feet away. You know, like it's not good. It's not good.
Well, it's everybody. I mean, Zoom's just not built for
I had
that.
to show her other podcasts that have had Zoom because I'm like, I've cleaned this as much as I can.
Yes. There's
nothing
only
left
so
to
much we
do.
can do. So, squirrel moment. We'll get back. And we also have Hannah in the building.
She's a registered dietitian.
Yes.
Works with Dr. D. So.
Yes. We're
cool.
so excited to have you on. And we're going to talk about, this is a very highly requested video. Episode because we did the complications on the sleeve.
Yes.
And so we got many, many messages. What are the complications for bypass?
Well, I think it's so cool that, you know, you guys liked the episode on the sleeve complications.
Yeah.
Because our whole platform and why you guys do what you do in the bariatric community is to really just break down the stigma around weight loss surgery and get more patients interested in it and making it more normal. Yeah. But with that, I like that people are making informed decisions. They want to really be educated about it. And I'm glad it was well received. And so we're going to be talking all things bypass today. And I have Hannah Schuyler here too, who's going to talk a lot about when things happen, what you can do from a nutritional standpoint, to keep yourself repleted and make sure you don't get deficiencies during all of these things, because that's a big part. That's actually something. It's almost like a silent thing that sneaks up on you if you're a bad boy or girl, bad patient who's not taking their vitamins. Those things can be a big issue, and I know we've talked a lot about that in the past.
Yeah, I mean, vitamins are huge, and we didn't realize how important they were for our journey until we started talking with ProCare and taking all the vitamins, and we feel so much better because I was not like on a schedule with my vitamins, and now I have an absolute schedule and I feel better.
Yeah, and we travel with it. Like ProCare stuff is in our freaking luggage.
Yes, I have all of it.
Nick really went into detail like why it's so important and what chemicals are really doing in your body, and like being like vitamin D deficient is not a good thing.
No.
You need to have B12s, like they're super important to things, and we're like, oh, we didn't realize how important this was. We better take those now. Oh crap.
Vitamin D does like everything in our body.
Right?
Yes.
It's like everybody's like, oh, it's from the sun. And it's like, no, it does like all the things.
It does all the things.
All of them.
Yes.
And so many people are deficient.
Yeah.
So then when you have absorption issues on top of that, like, Oh my God. Of course.
Okay.
I was severely deficient before I was.
Oh, me
for
too.
surgery.
Yeah.
Because after surgery, I had to have 50,000 IUs a week.
Mm-hmm.
Yeah.
The repletion.
Yeah.
Is that kind of normal to take that much?
That's like a repletion. So
Okay.
it would be like a course that somebody would take for a certain period
Got
of
it.
time. So if you were
Okay.
to check your levels and you were low, your doctor might prescribe you for that.
Okay.
Yeah.
But that would be bypass, surgery, not. That would be anybody.
Surgery in general.
Well, anybody.
Oh,
People
okay.
in general.
Oh,
Mhm.
Yeah,
to know.
because when Dr. Patterson did mine, she was like, "We have to start this now.
Yes.
This is not.
This is not good.
Melanie, this is
Ruh-roh.
bad. Yeah, okay, whoopsies.
Well, and being in Oregon, you're probably not getting the most sunshine
No.
out of anybody.
No. We were driving here, and I'm like, it is 80. It's 80 degrees
In
outside.
December.
In
This is
December.
weird.
I know.
It's great.
It's
I rode with
awesome.
the top down.
Yeah. Oh, there you go.
You guys got a convertible?
No. Hannah.
Oh, you have one?
I was borrowing one, yeah.
Excuse me.
Fancy.
And I think the bypass gets
Yes.
a rap for malnutrition too.
It gets a bad rap all around. So
Yeah.
I am glad we're going to break down some misconceptions about the bypass, and we're going to talk about if, again, very, very rare, but if something were to happen to you, what are those things and how do you help with those complications?
Yes.
Yeah.
Let's get into it.
All right, so to understand the gastric bypass complications, you have to have a relatively basic understanding of the anatomy.
Yes.
So I would suggest, if you, of course, are walking around, I would pause this and Google gastric bypass image so you can see it if you don't quite understand it, because it's confusing when I'm like, this goes here and this goes there, like without seeing the picture, it's
Yeah.
hard. So
Yes.
pull out a picture and check it out. So just to briefly review, your stomach will go from the size of a football,
Okay.
roughly, with the bypass, down to the size of about a thumb.
That's so crazy.
So we use sizing tubes to make that thumb size pouch, roughly. So I use a 32 French. It's actually called a bougie. We're talking about bougie convertibles over here. So
I promise it's not bougie.
so the stomach goes down to about that, and we measure it. And then what happens is the remainder of the stomach stays inside of the patient and it's bypassed, which is why it's called a gastric bypass, because the stomach is bypassed. So 95% is making the stomach or digestive juices that go downstream. And then when you eat food, you'll put it in your mouth, you'll swallow it, it'll go in the tube in your chest called the esophagus into that thumb-sized pouch, and now we hook it up directly to the small intestine.
Okay.
So food and drink goes straight on down. The bypass stomach in the first part of the small intestine does its thing. And then at the Y connection downstream is where they join up. All right, so there's different connections here. There's different staple lines and connections. And everybody, another plug, you should watch when you guys came into the OR with me
Yeah.
a few months ago. And they got to see the gastric bypass. They saw the instruments that we use. And you can see the stapling devices and that sort of thing.
The gator.
Yeah, and that's how I realized the thumb size really is a thumb size, guys.
Everyone sees it. I
It's
take
so
pictures
nuts.
of it. I'm like, oh, look how cute. And then when you put it on camera and see the remainder of the stomach, the 95%, you're like, wait, that's. Whenever I
Yeah.
show patients' families in the waiting room, I go through their pictures. I always take the same 9. And I'm like, this is their new stomach. And they're always, the family's like, wait. Like, how can that be? And then we go into the, and it looks surprising. However, you still can eat, upwards of 4 to 5 ounces of protein in a sitting with it. It doesn't seem like it can happen if it's that small, but you still can.
Well, your stomach stretches and around the food.
A little
So,
bit. Yeah. I mean, it's never going to stretch back out to the full size by any
No.
means or anything like that. But yes, you get more used to it with time.
Well, when the food hits in your stomach, like your bile and everything's like kind of contracting and moving around.
So
and
that's an
dissolve,
interesting
right?
question. That's such an interesting thing you just said. So bile. Okay.
Yeah.
So bile is made in the liver.
Okay.
Bile is stored in the gallbladder.
Okay.
So if you have your gallbladder removed, it can go directly down into some of the ducts into the small intestine. So bile helps to digest mainly fat, and it's having your gallbladder out is not the biggest deal because it's still being made in the liver.
Gotcha.
But the thing about this is why it's interesting, and it goes into the complication speech, is because bile is being dumped into the part of the small intestine that is bypassed. So traditionally, the bile was still always there, but you would start to, in the first part of the small intestine, before surgery, when things go through your stomach, through the pylorus, into the small intestine, bile will meet up with it right then. But now the bile has to travel downstream, and it doesn't meet up with the food until the Y connection. So the big thing I'm trying to say here is that if you are vomiting bile, If you're vomiting bile after a gastric bypass, it is a surgical emergency, period.
Oh.
You go to
So-
the OR.
How do you know you're vomiting bile?
If
Oh,
it's
that
like a
taste.
yellowish, a greenish,
Okay.
it's not just like spit or it's not just food. If you're on an empty stomach and something you feel very nauseous, you're vomiting, yellow or green comes up, it means that you have a bowel obstruction. In other words, your small intestine at some point around probably the JJ connection, which, by the way, is the connection of small intestine to small intestine. It's called jejunum to jejunum, the jejunojejunostomy. And that is the JJ connection.
I'm impressed that you said that. Like,
mean-
you got it all right.
There'll be a test at the end.
The thing about being in healthcare is that we basically learn another language so that everyone thinks we're like super duper smart. But in reality, it's like, but it's called the JJ for
Yes.
short.
But JJ.
So at the JJ, let's say you got a kink there.
Yeah.
Or an obstruction somewhere. If there's an obstruction, think of it like your pipes. If there's something blocking it, everything above it is going to come out. You could flood your bathroom. It could all come out and nothing's getting through. Big hairballs there, nothing's going to get through beyond to go all through the pipes.
Okay.
It's exactly like that. I'm kind of a glorified plumber, if you will, because if it's stuck there
Yeah.
and it's stuck so much that it's a complete obstruction, it's blocked completely. I always think of it like even like a balloon animal. If it's like kinked there, everything below that is like this like little shriveled up balloon. Everything above it is really dilated or distended.
Okay.
So your abdomen will be like very bloated. If someone's bloated, they have a lot of abdominal pain, or they're vomiting bile. They're going to probably have to go to the operating room.
Oh, that sounds scary.
So if that's the thing. It can be typically done laparoscopically. So a lot of times you're miserable. The intestines do not like to be kinked.
No.
They don't
that
like.
sounds painful.
They don't like to have their blood supply potentially compromised. So if you feel this way, so let's talk about a number of things. When can this happen? How does this present?
Yeah.
What should you do?
Yeah.
How do you know that it's happening? All right, so there's different things. There's right after surgery, and then there's long term. So these things are typically due to something called an internal hernia. An internal hernia is by rearranging the intestines. There's these little areas, two of them actually. There's one at the JJ area, and there's another one called Peterson's defect. So there's these, by bringing up the small intestine to hook it into the stomach pouch, you now have this one big open area.
Okay.
So what I have to do during the original operation is I close
Yeah.
that with permanent suture. You can check it out on the video
Yeah,
as well.
Well, I just pictured it because you did that for a long time.
Yeah,
I
that
remember
was-
you talking and just like.
Well, that was me sewing the intestines and things together. But this is me sewing together. I'm actually like sewing fat to fat with a permanent suture to try to close up that hole that I made.
Yes.
Okay, yeah.
Now, let's say in a perfect world, you lose weight, all of a sudden the fat dissolves, and then now you have this hole reoccurs. If the intestines snake into that hole and then they can't get back out, it can cause them to be angry and then potentially obstruct. So a lot of times what they do is the hernia means there's like the hole, the defect. I take the intestines back out of the hole, put them back where they belong, and then I have to re-sew that hole closed.
Wow.
What does that sounds such a random question? Where does that hole go to though?
So the hole, it's again, you have to kind of look at it in a picture. So it's when you bring up, so the intestines bring up to the stomach pouch. There's this area here where it wasn't there before. I created
Oh,
that.
you
It's like a
created the hole.
surgeon-made hole. I made the hole
Gotcha.
by doing the bypass.
Got it.
If you didn't have surgery, the chance of you having an internal hernia are none because you don't have these internal hernia defects type spots.
That makes sense.
So we make those. And
Okay.
so we know as a society, it's standard of care, you must close the hernia defects because that will help to mitigate this potential for things to slide in there and get stuck.
Got it.
Okay.
Okay, so how do you know you have a hernia?
Great. So the symptoms of this. So with a hernia, it typically happens years after surgery. So it's normally it's something that happens long term. It normally doesn't happen the first days after surgery.
Okay.
So you'll have this. They have a very distinct way of actually moving in their hand, and they'll say, when I eat, I get this severe pain, and it's like almost in this like very diffuse or very across the entire abdomen.
Okay.
Like pain right here in the center.
Okay.
It just feels like it's a lot of pain. It bears to my back.
Okay.
I have like really bad back pain now all of a sudden, and so then we'll say always go and get a CAT scan.
Okay.
So the CAT scan has a very characteristic finding, and it's called a swirl. It looks like the eye of a tornado, the eye of a storm. Because what happens is when the intestines go in there, they'll kink, and you can see their vasculature, their veins and their arteries. You can see them in it. So when you're scrolling up and down on a CAT scan when I'm reading it, you can look at it go like it's like twirling, like it looks like it's called a swirl sign.
Gotcha.
Now the thing is, so if you happen to go, let's say, you went somewhere and then you moved, and so you're not around a bariatric center. So you go to, your local ER. You get the CAT scan done, and then they say everything looks good. The thing is, sometimes this is to us, it's like 101 because it's such like, this is what I'm looking for, the mesenteric swirl sign.
Yeah.
But sometimes if they don't do a lot of bariatrics at their particular hospital, or the radiologist is just not thinking about looking for this characteristic eye of the storm, then it can be missed. And so that is something that to really advocate for yourself as a patient, if you go to an ER and they do a CAT scan, you should specifically ask, is there an obstruction? Is there a mesenteric swirl sign? They're going to be like, what? Say what? And if you should say, I really want the ER physician or the physician that's taking care of me, A, did the surgeon review the CT scan personally? And B, can they do, you can do like a consult with the radiologist where we go into their dark rooms and then we sit with them and look over the film. Like, can I say, you said that there wasn't anything there, but can we sit down together and look at this case? I'm going to tell you the clinical picture, because what they see is only the images. They don't know that they've been vomiting bile. They've been miserable with this this really it's intermittent. It's like waves. So as long as they're not eating, it's not bad. As soon as they eat, the intestines start to peristalse or kind of try to move things from your mouth to your anus, move things forward. So when you're trying to propulse food forward, when it hits that kind of area of kink or where it's kind of stuck, or edematous, in other words, swollen, it will cause severe pain as it tries to get through there. So also, if you are not passing gas, if you're like, I'm so bloated, I'm getting more bloated, and I haven't passed gas in a little bit, passing gas is way more important to us than actually having a bowel movement. Because because some things are in your system. Some people say to me like, I haven't eaten anything in days, I probably won't poop, and I'm like, yeah, but you'll still have something old in there regardless. Air, though, travels very fast. So the air that you swallow right now is what comes out by passing gas. And so it's very important that, okay, I had a bowel movement today, but did you pass gas? That is what we want to know. Did you pass gas? Vomiting bile means that there's an obstruction. And it's not going to typically get better by watching you. Let's watch and wait. Let's just give you some IV fluids. Let's chill. Let's see what happens. The wait and see game does not work when you're vomiting bile. If you had a gastric bypass and you are vomiting bile, I'm going to repeat it one more time. It is a surgical emergency. Go to your local emergency room.
Yeah, don't wait. I don't know why people wait.
Yeah, don't wait. Just go.
Because you don't want to be wrong, and you don't want to waste anyone's time. You don't want to waste your own time. You don't want to look silly.
Yeah, you don't want to look stupid. Right. And so, I mean, I've done that. I'm like, I'm just going to wait it out. No, you need to go to the hospital. Like,
I know.
There's no other way around it.
It's something that, we all do that where we don't want to look like we're a complainer or a whiner. Like, I'm tough. I can handle it. I'm tough. And sometimes I'm like, when I look at CAT scans and stuff, I'm like, dude, who are you? You are superhuman, but that's not a compliment right now. That's kind of crazy.
Well, when I broke, so I have titanium from knee down on my left side.
Oh, wow.
Because I have a spiral fracture that went from like all the way down to my ankle. So I have 5 screws in my ankle and 2 screws in my knee. And what's interesting is like when I went to Hope Orthopedics, I didn't know, I was so scared to like move because it hurt. But like they had to like assess me because no one would touch me because they're like, this is a very scary surgery. We're not touching you. We're in Salem. So they had to like figure out who could. So I had to go to this place and I didn't bring any. I was like, can I finally take my pain meds? And he was like, hold on, you're not even taking pain meds right now? I was like, I didn't know what you needed to do, and I just didn't want to have that in my system. And he was like, girl, I'm getting them right now. Like, you can't be moving around. And that's like, duh. Like, in my head, I'm like, why did I was like toughing that out? Like, it doesn't make any sense. Like, they want you to feel comfortable.
I know.
It's like, just be comfortable.
I know. Be comfortable and also try to go to a place that has a bariatric surgeon.
Yeah.
So as you know, we're general surgeons by trade, and general surgeons can absolutely do these operations. However, as a person that does the internal hernias, I know exactly like how to technically do it, to keep it laparoscopic. Again, that's the tiny little incisions instead of my need to go from a laparoscopic to an open incision is virtually zero. Like I don't convert to open. Actually, I've never done that. I've done over 4,000 surgeries, so I don't convert to open if I can help it. I'm actually so much more comfortable laparoscopic. And some surgeons are so much more comfortable open. So big incisions means bigger recovery and that sort of thing.
Well, in the air, right? Like you don't want someone to be open for too long. Isn't that like a thing or no?
No, that's not really it. It's more about afterwards, you could get a hernia at this big incision. You're in the hospital for days and days. It hurts bad. You could potentially have a wound infection, especially if you are still struggling with your weight and you have to go through more like adipose tissue or fat tissue to get into the abdomen. Healing after that is not good.
Okay, because I remember getting my gallbladder out before surgery, and so I was bigger, and I remember having it out, and it took me. Everybody's like, "Oh, you'll be better in a week, and no problem," and it took me like 3 weeks to get through that. So that makes more sense because they did open it because they opened me. Yeah.
Right. So, you had an open gallbladder?
Yeah.
Oh boy.
Yeah.
Oh boy. So you have the big incision underneath. Oh boy. That's special.
Yeah. Yeah.
That actually is the most painful, one of the most painful incisions because normally when you get into an abdomen, you normally go up and down in the midline. Because think about like pictures of like the way the six-pack muscles look, the rectus muscles, and then there's this like white line in the middle of it. So there's not much muscle. When you do a gallbladder, it's called a Coker incision. When you do a Coker incision, which extends from the xiphoid process all the way to your right side by your rib cages, you cut through transverse abdominis, rectus muscle. You cut through. You have to like cut through so much muscle and fascia and tissue that it is brutal.
It is very painful. It is very painful.
I learned something about you today.
Yeah.
I had no idea you had an open a Coker incision under that elephant, huh?
Yes. Yep. Well, and they wouldn't do my surgery for the longest time. They were like, "Oh, it's not that bad," and I was like, "No, I'm in pain. Like what? Like my gallbladder was like less than 7% function."
Oh, wow. So you had a really poor ejection fraction. So there, talking about gallbladder situations, and then I want to pull Hannah in here to talk a little bit about how you recover. Actually, let's not go off the internal hernia conversation yet. So internal hernia, bowel obstruction. Let's talk about you've had the procedure and now you're going to be recovering from it. Okay. So I want to just recap on the importance of what types of like nutrients you need to be taking, because when you're sick, you have another surgery, you're going to deplete your stores very quickly. Okay. So afterwards, all these things are like the foundation of like the vitamins, the calcium, the food that you should be eating. How do you kind of like get your strength back and restore yourself so that you can start functioning a little bit better?
Yeah. Yes. We get that question a lot.
Yeah. Well, with any surgery, and this is weight loss surgery, this is general surgery, this is anybody, protein. Because like protein heals. And so it's so important to get that in. And I would say if you're not feeling well, get the shakes. Like that's totally fine. It's going to be easier to digest. You're going to feel, kind of go back to those really basics. And then of course the other thing, and same, this is any surgery, fluid. Don't get dehydrated. Like you were just in the hospital, you just had surgery. Don't go back to the hospital now because you aren't drinking your fluids. So, and then of course it's taking the vitamins, because like I said, vitamin D helps with literally everything. All your B vitamins are going to help with that restoration and that healing process. And when you've had like gastric bypass and you're not absorbing like you used to, and if you think about vitamin and mineral intake, like so many people are deficient in things anyway, and we're eating a full-sized caloric amount. Yeah. When you cut those calories down and the intake down, you're just never going to really meet those needs based on the amount of food you're taking. And that's why the vitamin and mineral supplementation is so important as well, because you're not absorbing it as much and you're just not able to get it from food. It's not realistic. Okay. And so just making sure you really get back to that foundation. And I would say rest. I mean, I'm always a proponent of rest.
Thank you, ma'am.
Yes,
Preach the rest.
And I think so many people want to push it. They're like, again, it's going back to that tough it out thing of like, well, I'm strong. I can do this. I can go back. It's like, no, you just went through surgery. Like, and your body is maybe, and again, depending on where you are in your weight loss, you may also be fighting chronic inflammation. You might be fighting some other kind of some issues going on systemically. So like, take the rest.
Yeah, your body and your brain needs to shut down for a little while.
Right, exactly. And I think that's a good point too. Mental rest is so important because like mentally being stressed about it, you know, people just do too much. That's the reality.
People think they can do way too much. I do it all the time.
Right.
And it's frustrating. And it's like, no, we still have to sleep.
Yeah. And of course, then you think what's the percentage of women that are getting bypass or getting bariatric surgery is so much higher. So like childcare.
Yeah.
You know, get someone to help you out.
Oh, I know. Oh, I hear that all the time. Like, so can I go home immediately after surgery and can I like do everything for my like 2 toddlers, you know, that you hear? Yeah. You're like, oh, geez.
Well, that's the reason why they say it takes a village to raise kids. Because it really does. You need more than just the mom or just the dad sometimes. You need like multiple people.
Yeah, especially
Use
with
the help you have.
Yeah.
Right.
You're utilizing your tool in your stomach. So utilize the people that you have in your life and kind of set it up. Haley, who we have on the Bariatric Diaries, she actually had people that while she was on liquid diet, she had her friends and family, like they brought her meals for the family. Yeah. So that she didn't have to be cooking.
That's a great tip.
Yeah. And they actually set it up for a month, 2 weeks before, 2 weeks after. And all of her friends like shared making meals for her and like really checking on her and very supportive.
Yeah.
Very
she
supportive.
has like 3 kids.
Yeah.
So like,
wow.
Yeah.
Her husband has 2 and she has 1, I believe.
Yeah. So
wow, that's what you have to do. I just went to this there's actually a place here in Florida. It's called the Human Performance Institute.
Oh. Okay.
And I was invited there as part of this dinner. It was such a cool thing, but something a little different. We took a tour of the facilities, and then they told us a little bit about their like mission and how there's like they bring a lot of people from like corporations there because they consider them like corporate athletes. Oh. So like how do you perform at your highest level in all of life? So they have all this thing about like how do you break like linearity in what you're doing? So let's say you're standing, you might need to sit. If you're sitting, you might need to stand, or if you're standing, you might need to move. Like how do you like constantly like help with your body? But there was one concept that they said, which is when you're under stress of any type, like you're saying, physical stress, mental stress. In this case, of course, it's your body, or you're really, really, really stressed. The only way to ever get back to it is to have a full recovery. It's about this yin and yang of stress and recovery. But in stress is where you progress to, where you move forward. So I know some of these things are like, what's the good in this? But it really just makes you think.
Recovery is just so important. Like you can't get back to what you want to do unless you're fully recovered. So stop trying to do stuff when you're not fully recovered yet.
Exactly.
I feel like you're talking to me.
No, actually, I'm talking to Anne, if you're listening right now, because she had foot surgery like right before Thanksgiving. And she is stubborn and wants to make sure her house is clean for Thanksgiving. Family's coming over. And so she will randomly like try to walk on it. And Missy, you got a staph infection. Ooh. So now your recovery's a little bit longer.
You better be careful with that. You could get an amputation.
Yeah. Right. So I love you, girlfriend, but stop being so stubborn. You guys need to get your
rest.
You guys
Sit down, Anne.
Recovery. And side note with the protein, like we heard that from Dr. Beatus. Like when you get plastic surgery, he wants you up to like 130 grams of protein, like huge amounts. And then I also watched an interview with Travis Barker, and when he got in that plane accident, for his recovery, he's a vegan. And it was taking really long, and they told him, like, you need, like, animal protein. And he finally did it, and then he recovered really quickly.
Wow.
So, like, there is a real thing with protein, guys.
Yeah.
Like, get your protein in your meats and your veggies.
Well, and that's why you say, like, you have to get this amount after surgery because it does help with recovery. And, I mean, the water and the protein, you just have to balance it.
Yeah, I know you guys hear it over and over again, but sometimes you hear it, wait, you gotta like, am I actually doing this? Am I actually applying this to my life and my, my everyday habits? Is this my routine? And if not, I mean, we're fortunate enough to have Hannah here on our team, and hopefully you still have contact with your own bariatric program, and you're following up with your dietitian, you're getting your labs checked, you're taking your vitamins and your protein and all the things that you need to do.
Well, and I challenge you, like the people that are listening, just do it for a month. Drink all your water for a month and drink all your and get all your protein. Just test it, because like I understand the whole like Charlie Brown wah.
Yeah,
like,
that's exactly what I was thinking.
Yeah,
and
we talk about it all the time. But until like until you guys actually do it, you'll know why we're saying it. Because you can feel it in your body.
It's almost like we know what we're talking about.
Yeah, almost. I mean, I'm still on the fence.
They didn't go to all these years of school.
Yes.
That's fine.
We don't say it all the time just because we feel like it.
Yeah.
Right?
Yeah.
And we're not saying these things just to hear ourselves talk. Like,
I know.
there's a meaning behind it.
Yeah.
And I think that's with anything we recommend. It's like 30 minutes of exercise. Well, I can sit there and say it all day long, but once you do it, like you said, you feel better.
You feel
Once
better.
you do these certain things, it's like, oh, okay.
Well, the thought of it is, I think, overwhelming because you're taking it
course.
as like, oh my God, I have to get 64 ounces of protein or water. And you're like, how am I supposed to do this? You take it, you say, okay, I'm going to take 10 here. 10 here.
Yep.
You break it up
Absolutely.
because the big number looks so overwhelming.
Yeah.
And, just same with exercise. Like, just getting to exercise seems so overwhelming. And I know a lot of people going into the gym for the first time after surgery, like, it's scary and it's overwhelming. But once you're there and you're doing those things, it's fine. You've got this. It's just the whole picture can be overwhelming.
The first step, too.
Yeah.
Actually, I heard something. You two are going to love this.
Oh.
And let me do the post first, and you guys can steal it if you want to. Okay, let me make sure I get it right. The first step in kicking ass is picking up your foot. So it's like you have to take the first step, and then you can start to do it.
Wow.
And it's always about the first step, the first click to the website to get started with your weight loss journey. The first, the day that's why I love New Year's. And you can do this any day, obviously, but I just love the idea of let me reevaluate my life and let me get back on track.
I love it too. I hate that they kind of fall off, like, because a lot of people use New Year's as a tool to like, okay, I'm going to get healthy. And then 3 weeks in, you're like, okay, well, that didn't
I know.
happen.
Well, also people set terrible goals. Like,
Yeah.
what a terrible goal that is I'm
Yeah.
going to get healthy. What does that mean?
Yeah, what
like,
does that mean to you?
And that's what you're saying. Like, when you look at this big picture and you say, oh, my God, I need 70 to 100 grams of protein. I need 64 ounces of fluid. Like, ugh. But if you say, okay, well, this hour I'm going to drink 6 ounces of fluid, and then the next hour I'm going to drink 6 ounces of fluid, and like I'm going to get through it, that's a real goal to set versus every single day I'm going to meet this gigantic sounding goal in my head.
Yeah. And I actually set an early New Year's resolution.
Yeah? What is that?
So I decided that once a month I'm going to try something new
Oh,
that I've never
I
done
love
before.
that.
So we were actually talking about it, and I was like, I feel so much better when I do those things because I'm realizing, I am living my life. And so I'm challenging everybody to do this. Like,
Yeah.
So, okay,
'Cause I
tell
went
us
through
what
that
you've been
phase.
doing.
Yeah, what's your first thing?
So the first thing was Disneyland because I'd never been to Disneyland. And so I went on all these rides. And even though I was scared, like we went to California Adventure and the Incredicoaster, it goes upside down. And I was like, I don't know about this. But I went on it and I had a blast. And we ended up going on it 5 times. Like, so I found something that I really, truly love because I tried something. I risked it.
Yeah.
Like I was like, okay, just do it. Because if it doesn't, even if you're a little scared, just do it. And it's the same with the bariatric surgery. It's scary. Yeah. It's a surgery. But if you take that first step and you move forward, like look at how much better our lives are.
Seriously.
Just because we decided to take a chance on ourselves. Like we
Believe in yourself.
and we
That's
put
the
ourselves
deal.
first
Yeah.
for the first time.
Wow. Let's talk about surgery. Let's talk about these surgeries and taking that first step and believing in yourself, because I have a feeling the people who are really attracted to this episode are the people who are still pre-op.
Yes.
And they're
Yes.
you're just devouring. You're like drinking out of the water hose everything you can get and make sure you're prepared and make sure you understand it. And do I want to do it? Let me listen to this one with one ear. Do I want to hear about the complications and all of that?
Right?
And we talk a lot about in our other Dr. Dovec Diaries about what surgery should you pick, and we were just chatting before the podcast started about the trends in bariatric surgery.
Yeah.
So the trends have been just so fascinating. You guys should Google it, and you can see the images of the spike. So there's the big spike of the vertical banded gastroplasty or stomach stapling. Then there was the big spike in lap band. And then there was the bypass kind of made a comeback. And now it's really on the up and up still with the sleeve. However, it's been very interesting in that the gastric bypass has always been a player. It's been a player for over 60 years.
Oh wow.
It's
60.
been
I didn't
it's
know
the
it was
longest
60.
one. It is the original. It is the icon. It is the one that is very hard to remember.
Grandfathered
It's grandfathered in. It
not
keeps
going
showing
anywhere.
up. This guy, he keeps coming back. And it's something that is, it's hard to replicate the results of the bypass. There's a lot of little slick things, and we're always constantly innovating and progressing and learning with medical device companies and the techniques and our collaboration amongst our partners, all that stuff. I mean, we keep advancing the field. However, it's interesting that I do think the bypass is going to make an even bigger comeback. It's going to be it's on the upswing, I think.
Yeah.
I think the heartburn is a big player in that.
Absolutely. After the sleeve.
Yep.
That's something that we talked about on the sleeve complication issue at length about, but it's important to think about that. If you're out there listening, and the thing is, the sleeve is really, really popular because a lot of people are getting it. You ladies both have had the sleeve.
Yeah, we both had it.
And have done incredibly well.
Yep.
Operating time is a little bit shorter with the sleeve. It seems to make sense. Your anatomy is the same, just removing the storage capacity of the stomach. However, the acid reflux, my friends, I'm just going to say this one too.
It's real.
So, yes. See, that's the thing. Kella's experiencing a little bit of acid reflux now after the sleeve. So, I'm going to tell you, if you're before surgery, if you're pre-op, and you have a great deal of acid reflux, if you have a hiatal hernia, if you take medications that are either over the counter, like Nexium, omeprazole, Prilosec, Protonic, something like that.
I feel like she
Tums.
named like 2 things that you take.
Yeah.
Oh, you're taking more than one agent?
Well, at one point I was. Not anymore. I'm just taking the one. But
So
they
yeah,
did
if you're
up
taking meds, if you're somebody that like, you've ever been to the ER because you thought you were having a heart attack, but it turned out to be reflux. Time out, my friends. Listen, I know that a lot of people, again, put their fingers in their ear about the gastric bypass. I don't want that one. It's way more complex. It's way more invasive. It's I always see people who've had it and they seem to regain their weight, or they're always vomiting, or they have diarrhea issues, or all those things are not true. They're not true.
That's what I heard, and I've said a couple of those.
I'm sure you did.
Yeah, 100% with the whole invasive thing. That's why I was scared.
So the funny thing is, invasiveness. So I actually did training. My fellowship is in minimally invasive surgery, MIS. That's what we're trained in. We're minimally invasive surgeons. In other words, we do it laparoscopic, which is the little tiny incisions that I'm sure the majority of you have had out there listening or will have. And so the thing is, it's not more invasive. If I were to line up 100 of my patients who've had sleeve, bypass, revision, whatever, they lift up their shirts, they all have the exact same incisions. 2 inner near the belly button, and then 2 pinky-sized incisions out to the side. So I use the same 4 little tiny incisions with all of it.
Wow.
Oh my goodness.
Yeah, I think that, and I remember when we were in the OR and we watched you do the bypass, we both were like, we wish we had just done to the bypass.
Wow,
we
that's
both,
an admission.
Yeah, we both thought, we were both like, that was not as scary as we thought it was going to be.
Well, and we can admit that we were wrong. We're like, yep, that's not at all
Wow,
what I thought it was.
Yeah.
And I kind of wish I did because, like we've said before, is that I wish I could have just got a little bit less. Like, just got that way when my 12 pounds that I gained could just be at a different level. Because I know the bypass I could have lost just probably like 20 pounds more, I think. Because, like, I only got to 179 was my lowest. And so I'm like, I feel like I could have got to 160 with the bypass.
Yeah. I feel like the acid reflux, I'm like, I should have just done. I did not want to do the bypass. I was like totally against it. And so my surgeon, Dr. Thompson, she was like, I can do the sleeve because your reflux is under control. But I had GERD. I had it was painful. Like I would be hunched over because it was so awful.
Oh no.
And then it kind of got controlled, and so then I did the sleeve, and now it's coming back. Like there's times where I'm sitting in the car and I have to stretch back because I can feel the pain. And
so there's 2 different reasons why reflux occurs. So the one reason is that as you get heavier, your weight pushes on your stomach, which then kind of pushes on your diaphragm and causes things to reflux back up. So it's sort of that. If you think of the phenomenon of pregnancy and when the baby grows, you get these, some mothers get a lot more reflux. People say, oh, that must mean there's a lot of hair on the baby's head. But it's really, it's like, no, it's like kind of it makes sense. I mean, the baby's kind of pushing on your stomach. Yeah, it's just kind of like physics and, here as to why it's happening. Now, so some people will actually, like you experience, you start to lose weight, it starts to take the pressure away, and next thing you know, your reflex is better, and this is great. Now, we talked about this on the sleeve complication, but at the end of the stomach is the pylorus. You have a skinny stomach that closes. It can pressurize. In other words, things that sit in your stomach, they can be driven. It kind of pressurizes it back up. And the way that you can really diagnose it is either by doing an upper GI swallow study, which is done in radiology. Again, you drink contrast, they shoot an x-ray, and we see if the contrast goes in or does it go back up, and to what level, what severity. And the second way is you can have an upper endoscopy, which is where you, typically either a gastroenterologist or maybe your bariatric surgeon themselves will go down with a camera or a scope down into your esophagus and into that stomach, and they can see, is there any irritation? Is there a hernia? And again, a hernia is when the stomach, which should be below the diaphragm in the abdomen, has herniated or gone up through the diaphragmatic hiatus into the chest and is now sitting next to the heart, which is why it's called heartburn again, because your stomach should be in your abdomen. So when the stomach is up in your chest and it's next to the heart, you're like, wait, am I dying of a heart attack, or is my stomach like making acid here and it shouldn't be here?
Yes.
Like, that kind of thing.
Oh, that's bad. That's real bad.
That's real bad.
Oh my gosh. I'm having pain right now. So I'm like,
Because which one are you having on Monday?
I am having the swallow test.
Nice.
Yeah. So I'll do the swallow test, and then she said after that, if that doesn't show anything or anything, then I'll do the endoscopy. So
I'm curious. You should almost do like an Instagram live of your results. It's like, okay, the reveal is, oh no.
Yeah. I did some videos when I went back in, and that was really weird.
Yeah.
Like being in the surgery center again, and like not just for a checkup. Like I was in there for like to see if I need another procedure, and that was really strange because I was like, no, I'm supposed to be like done.
Yeah.
Like why am I mean, I love being in there because all the people are amazing, but it was different. It was a different feeling.
Well, it's something interesting. So I pulled up the American Society for Metabolic and Bariatric Surgery. Their trend, the last one it looks like they have is from 2018, and sleeve is still like climbing, just climbing. But it looks like gastric bypass has really plateaued, which could mean it's starting to rise. But what's been rising is revision. So like if you look, I don't know, you can see it's like the bottom blue line. It was like
it's starting to go
it's
up.
starting to really like go up on the revision, which that's
because it's usually a few years out, right? That you start to get the reflux and everything. So if you had your surgery in 2018, by 2020, you're starting to experience that heartburn feeling or that pain in your chest. Because I'm almost 3 years out.
Right.
Yeah. So I'm like right in that space where it's going to start bugging me.
I know. I hadn't seen my patients in a while, and I'm like, uh-oh. And that's another thing. We were talking a little bit earlier about going to the ER and hoping that people, you're not wasting anyone's time. I have to always, if you come out of the blue 3 years later, you come into my office and you tell me you're having reflux, why would you lie?
Yeah.
Why would you? So I have to always remember, like, sometimes it's just like human nature to be like, this isn't that bad. It must be bad. You're taking time off of your work, your life, your job, your everything. You're driving there, you're going there, you're making an appointment. It's an inconvenience. So I'm going to review this thing to the best of my ability to say, we got to get to the bottom of it if you feel so compelled to come here and get it checked out.
I appreciate you saying that, because when I was diagnosed with my autoimmune diseases, I thought I was crazy. And I went to so many doctors, and none of them could tell me what was wrong with me, because I'm like, well, I'm having flu-like symptoms, but it's only for like a day and then I'm better. Or I'm having really painful hands, and they were like, well, but you're a photographer, so you're holding a camera all day, so it makes sense that your hands would hurt. And that was.
I don't think of that.
Yeah,
this phone hurts so bad.
Yeah, exactly. And so when I finally got somebody to refer me to a rheumatologist, he did the tests, and I came back in, and he was like, it confirmed that I had 3 autoimmune diseases, and said that it was like one of the highest levels he had ever seen.
Wow.
And he had been in the business for 20 years. And he was like, I'm surprised you're standing here. Like,
crazy.
And the like emotion of feeling not crazy was so much, because I was like, okay, finally I have an answer. And the answer sucked, but I had an answer, and so I no longer felt crazy.
The unknown is scary.
Yeah. Well, and you don't want to feel crazy. You don't want to be like going into a doctor when you don't really need it. Like.
I know. And I talk all the time about my infertility journey and that whole thing. But I struggled for like 3-4 years, all of these things. And finally, they kept saying, you need to have a diagnostic laparoscopy. So I was like, I don't want to. So when they came out and then they saw like I had all this endometriosis, there's different staging. It was like stage 3 or 4. They're like, I mean, it's like in your tubes. I don't think they're going to be able to get pregnant without it. I remember, even though I just came out of surgery, like we found something. I remember being so euphoric because it was like, oh my God, like, yes, you're answer. Validated. Yes. You're validated. Yes. But why do we feel that way? And I'll tell you, I mean, not just to put a shameless plug on us and what we do, but I don't think that way about my patients. When people, if you Instagram message me and you're out of the blue, I will give you my best opinion I can. Hannah does the same thing with her nutritional advice and how do we like cater to, like if you're Travis Barker and you're a vegan and here's like tips and tricks and customize. It is so important that you find a program out there, my friends, that you feel like they are going to be there for you for the long haul. Yeah. You need that. And we talked a little bit about this on an Instagram live I did with Kristen on Bariatric Meal Prep the other day. We were just talking about when you look at like the data, like we have to report it to that national database. And even we look at things like weight loss. So I look at the national levels of weight loss and I look at my own personal and my partners in our program's weight loss. Ours is a lot lower. And it's like, so are we doing a better technique? I think it's probably all the same. Like, is it some magical like IV fluids in the hospital or some clinical pathway that you did that did it? No, it comes down to the mental stuff and the support and providing a very nurturing, safe community where you can feel vulnerable to share your struggles and to be listened to. That's what you need to find.
Yeah. Yes. And I would say even from my end, like I spoke with a woman last night who was one of your first patients here in Orlando, and she's like, I'm doing really great, and I've got my follow-up next week with Dr. Dovec and everything. And she's like, but I might still make an appointment with you. And I'm like, great, do it. Like, even if you're not struggling or you're like, maybe there's some other little things that I'm not thinking of, like, you also don't have to let yourself get to the point where you're like, totally struggling or I'm gaining weight or, like this, that, the other. Check in with us, like that's my job. Like, that's what I do day in, day out. Like, I talk to you guys, and if you want to talk to me about, like, what your kids are doing in soccer, like, sure, I'll talk about that, too. Like, one guy was giving me wedding photographer recommendations. Aww. Like, it's just, like, those funny human things. Connection. But it's this human connection, and I think that's really – and that's such a dietitian thing as well. I mean, I come from dialysis was my previous job, and – that was the biggest thing. It was like half the time I wasn't talking to patients about their diet, but the end of the day, we were getting better results from them because they were listened to, they were felt. And that's honestly like, I feel like so many people think, healthcare providers are just like, they're in and out, and a lot of people are busy. You're busy, Dr. Dovec, like your schedule is jam-packed, but like that doesn't mean we don't care, and it doesn't mean we're not listening to you. And so I think bringing those problems to us before they reach that level of like, it's a problem. Like, come and talk to us because we want to help.
Well, and if you think about it, you guys wouldn't jam-pack your schedule if you didn't care.
Right.
There would be an open schedule.
There would be patients to put on there.
Exactly.
You'd be like, peace, I'm in Florida. We're going to the beach.
Well, I can't tell you how many people have messaged us and said, my provider isn't answering me, or I don't feel comfortable going back, or I've got this question. We'll be like, message Dr. D.
And they do, and that's fine.
Yeah, I'm like, she'll answer. Yeah. Because you're needing some type of answer because you are feeling unvalidated. And it's so awful. But interview your surgeon. Go visit a bunch. Yeah. Or just contact Dr. D.
Yes. Now, Hannah, I got a question somebody wrote me on Instagram a few days ago, and I love the question, and I would love your perspective on it. So the question is, what do you consider to be someone that you know beforehand? Like, what do you think are the great traits that will make them the most successful? And to that, what do you think will make them have a successful appointment with you? Like, should they like journal and all that kind of stuff? Like, what do you think is great when they bring this? You're like, oh, this is going to be a good one.
My favorite is, one, people that are willing to talk to me. And this is anybody, some people just, they show up. I'm all virtual. So they show up and they're just like sitting there, or the screen is pointed to the ceiling. So show up show up prepared. Ask, like, I love people asking me questions. I can sit and plan a talk with somebody all day long. I can give you an outline of, like, this is what we're going to talk about today, and these are the things I want to go over. But some of the best conversations I've had with patients are one where they're just like, well, what about this? Well, what about that? Like, ask me, because I don't know your entire life story. So just knowing what you want to know is super helpful, because some people also, like, we use the New Try program that's all online. Some of them have, I talk to them in various stages of them going through it. So some of them are like, oh, yeah, I already learned about the protein. Like, you don't need to tell me about the protein because I already read about it. What I want to know is, what are recipes? What are good products? People want product recommendations all the time. Oh my gosh. And I have not tried all of the proteins, guys. Sorry. But I think that's the person that is going to be successful, is that they know what they don't know and they're willing to make changes now. That's the other thing. People that are willing to make changes prior to surgery, and I'm not saying you need to go and lose 20 pounds. You don't need to be, you're struggling with weight loss anyway. I'm not going to tell you need to lose more weight on your own, because that's the issue you've had this whole time. And that's why you're with us.
Right.
But making the changes, making this, and it can be the small steps. It can be the walk for 10 minutes. It can be, it doesn't have to be anything crazy. But the people that are willing to make a change prior to surgery are the ones who are going to be successful with making changes after surgery.
Well, I feel like if they're way more honest with you.
Oh my gosh, that's the other one.
Right?
Honesty.
Yeah.
Don't lie to me. I'm not judging you.
Yeah.
Yes.
I am no perfect human, and I have no judgment to you. This is my education. Like, so yes, I might know a little bit more than you. That's, again, it's my job.
Yeah.
But
I think I would want that.
Yeah, exactly. and again, coming from my background, like, patients used to be like, I'm going to be honest, I've been drinking sodas. And I'm like, thank you for telling me, because otherwise I'm trying to solve a puzzle that I don't have all the pieces of.
Exactly.
And,
That's perfect.
like, give me the pieces so then we can solve it. So then we can find the root of the problem. What do we need to change?
Well, I think it's hard to admit those things. So, like, saying, like, oh, I've been drinking soda, or I've been eating a lot of sweets. It's hard to admit.
It is.
Because you feel like a failure.
You're like, why did I sabotage myself? Like, what am I doing? Like, you're a loser. You should be ashamed. There's a lot of shame, but you have to cut it. You just have to just stop the stuff with yourself and just be honest. And you're right. You have to know yourself to improve yourself, and you have to help. If you want help, we're here to help you. But be open to it.
Well, yeah, 'cause when you say it, it becomes real.
Exactly.
That's true too.
We had a message the other day, and and she was saying how she's been eating a lot of sweets, or not things that she knows that she should be eating.
Right.
And I was like, hey, just because we had the surgery didn't erase the food addiction. It didn't erase the constant need to fill ourselves with that food.
Right.
So it's okay, and you're admitting it to yourself.
Yeah.
Like,
and that's how you can make a change.
You know that there's a behavior problem, because, what did she say? Oh, she had some chips at a Mexican restaurant and then took a drink of water because she knew it would wash it down and she could eat more. And she was like, I've done it a couple times. And I was like, but you're admitting it to us.
Yeah.
Like, you're saying it out loud, and you know that there's a problem.
Right.
So, and that's when I said, like, it doesn't erase the food addiction.
Well, and it doesn't erase our culture that we live in either, where, we're bombarded with food constantly. And food is necessary to live. Like,
Yes.
I'm never
You
going
need
to
it.
tell you not to eat anything. And that's what makes food addiction so much different than alcohol addiction, or if you smoke cigarettes or something like that. You can live your life without those things. Food, you can't. We can't just not eat.
Yep.
Now, Soylent would probably have you believe another thing, but, like, that's
do
not a
have
plug for them.
I do have a question
Yeah.
for you. So, like, when we have these complications with bypass, what kind of diet does that look like?
Again, I think it just goes back to the basics.
Okay.
It goes back to, like, let's see, of course, with complications, I think go to the doctor. Like, she is the expert in the anatomy and all of that. And so once you've figured out what the problem is, and that's really what it is too, what is the actual problem, and what diet changes do we need to make? Does somebody need to maybe go on to lower fiber for a period of time so they're not causing stress? Are they drinking carbonated beverages, and that's what's causing the problem, and we need to cut those out? Are they, doing some of these other things? So I think it's yes, it's going back to the basics, but it's also like, let's figure out why this complication is happening so that we can find an individual solution for you.
Yeah. You'll set up a plan and be like, okay, this is what you need to do.
Exactly.
Yeah.
Okay. So I know we have to hop off really, really quick, but I want to ask you about the resorption. issues with bypass?
So the big thing about malabsorption is in terms of we are bypassing some of the small intestine. So there's certain things that are absorbed in different places of the GI tract.
Okay.
So in the first portion of the GI tract is called the duodenum. And in this particular part of the small intestine, the first part of 3, it goes duodenum to jejunum to ileum, and then into the colon, the right colon, and then around, and ultimately the rectum and the anus. But the duodenum portion is where divalent cations are absorbed. That is calcium and that is iron. So that is why we've talked about this previously, but just to remind you that you must at least separate the two, the calcium and the iron, by at least 2 hours because they compete for absorption just the way that they are. So that's why if you're taking iron, at least a minimum of 2 hours before you take your calcium citrate.
Okay.
Hannah, what do you think about any specific recommendations in terms of just interesting anatomy pearls?
Well,
or
I think everyone thinks
physiology?
B12 because it's the stomach, and so that's something to consider. But again, it's all going to be in those multivitamins, and that's what I said earlier. Like, you're taking the double dose of the multivitamin, so you're going to be taking a higher dose to cover for the fact that we might not absorb all of it.
Right.
We know that some of it is just not going to go through. We're going to pee it out, excrete it somehow, like. That's fine. So that's why we take more. And I think that's really it. So just and getting your labs done. That's the other big thing. Check for deficiencies. Go see your surgeon. Have your annual appointment with the surgeon or the advanced practitioner or whoever or even your primary care doctor. They can pull labs. No, nothing wrong with them. They can pull a lab.
That is an awesome point. You know what we need to make? We need to make, this will be such a cool graphic that's going to go viral. We need to make, you guys make it on camera.
I'm on it.
I know. Actually, she's creative too. I'm, like I said, I'm getting old. I don't know. I'm not as slick anymore with my stuff.
Old ladies on wheels.
This old lady, here she is again. Oh my gosh, sit down, girl.
Oh, no. Nobody's saying that.
Oh my goodness. So what we need to do is have a graphic that has exactly the labs that need to be ordered. So if you go to your PCP right now, your primary care provider, if you go to them and say, I would like you, my surgeon isn't even practicing anymore, what have you.
Yeah.
And you say, I need labs. A lot of times they're like, I don't really know which ones. And they wouldn't even understand, like, we need PTH, which is how you look indirectly for calcium levels, or we need, vitamin B12. And even though normal range is like 230 to 1100, we as bariatric providers think that a deficiency is less than 500. So even though it may appear your labs are great, they're normal, you need that number to be over 500. So you just need, there's certain nuances. So we should make a little thing.
Yeah,
we should pin it. And so that way everyone can just easily take it. And then anyone can order the labs. It's just a simple recipe. If it's between this and this, you're good. If it's above or below, okay, this is how we're going to adjust it.
Right.
Cool.
I
I
love
love
remembering
it.
to do it regularly.
I love that.
Because you can do it once and then never do it again for 5 or 10 years. And
Exactly.
What's happening
And by
in the
regularly
background.
means
Yeah.
a minimum of every year. And if you have a lot of deficiencies, you should get them. You start to take the supplementation to help to mitigate that, and then you ultimately do the labs again to make sure that the treatment plan that you are on is actually
works.
effective.
So about 6 months, every 6 months if you're having an issue, or
if you're
every
having
3?
an issue, yeah. I mean, it depends on the degree.
Yeah.
Like when you said you had vitamin D deficiency, I was like, I wonder what it is. So the normal range for that is 30 to 100.
Okay.
Almost everybody we see is in the 20s.
I was
Oh,
like,
yeah.
Were you a single digit?
yeah.
Okay, that's
my dialysis in Chicago patients were like 4s. It was wild.
yeah, I was like
So-
it was like a 3 or 4. Yeah.
Okay, that is absolutely horrific. So that is something that that sounds alarms more so than if it was 29.
Yeah.
So 29, I will tell you to get over-the-counter vitamin D3, little soft gels that are 5,000 international units or even like 1,000, 2,000, fine, cheap, over-the-counter, fine, go for it. But you were on a prescription strength 50,000 international unit per day amount, because if you're in single digits with your vitamin D, do not pass go. Do not do anything else. Go immediately over to your provider and get a prescription strength. Go to your pharmacies and start it ASAP and get more compliant on your vitamins, please.
Well,
Yes.
I felt the difference really fast.
Yes.
Like it was insane. It was pretty intense. So, is there anything left to talk about for complications, Dr. D?
So, I mean, there's so many little nuances that little random things can happen. The internal hernia is very rare. I just want to say that again, that it happens 1 in every 200 bypasses roughly.
Okay.
So, and just to put into perspective, the people who need sleeve to bypass revisions is 1 in 20.
Wow.
So it's when you think
common.
about it, it's more common compared certainly to the bypass. There's acute complications, which we didn't really get into, which includes some similar things as with the sleeve, including like leak. You could also have longer term an ulcer that can perforate. We talked a little bit about that on the complications one. And then, there's other little things that could happen right after surgery, little wound infections, urinary tract infections, atelectasis, which is when you're not taking deep breaths. So the little bases of your little tiny airways at the bases of your lungs could collapse. It sounds
We should do number 3 of all the acute stuff.
Yeah.
We should do another one, guys.
Yeah.
You want it? Comment below.
Yes. Go to the
right.
website. Leave us some comments. We always love hearing from you guys and getting your questions. Find us on Instagram, Facebook, wherever you want to do. We've got Hannah. She's on Facebook or on Instagram now, and of course, Dr. D's on Instagram.
right.
You're all following her.
And if you guys want to join our support group that we have, where me and Kelly are in it personally, we
Yep.
talk to you all day long, go to patreon.com/OSLP and pick the tier $7 or higher. If you do the 10 one, though, you get a personal video from me and Kelly every week. Every week. And it's like an insider 20-minute.
Yes. We talk about our lives. We talk about random things. The last one, it was so random.
It
We were
was
just
so
like,
random.
blah, 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 blah.
And it's fun because you get to see an inner side of like what's going on with us.
Exactly.
So.
And the winner's bench, because we are changing the term. We don't like loser's bench.
No, we do not.
So
Great.
we are all winners. So we fondly call them benchies. And it is a fabulous group full of just very supportive people, and no question is off the table. And we just love them so much. So
Yeah, and if you're a guy, you can still join because we have Jeremy in there.
yes, we have our resident boyfriend.
That's right.
And
nice.
Yeah, and he comes in and he talks to all of the girls, and he knows that we call him a resident boyfriend. So.
I love it.
Yeah.
Bariatric boyfriend.
Yes,
Yeah.
exactly. So, all right. Thank you guys for being here.
Thank you
Thank
so much.
you.
Thank you for
Thank
hanging
you.
out with
This
us.
was
Awesome.
Yes.
Yes.
And we love you guys.
Guys.
And we will see you next time. Bye. Hey, listeners, if you've enjoyed your time with us, please rate, review, and subscribe on any platform that you get your podcasts. Also, check us out on patreon.com/OSLP for exclusive content with your favorite girls ever.
Yeah.
And also, check out our YouTube page. Subscribe, hit that little bell so you get notified when our new videos drop a week after they are released.
Yeah, and we would like to give a big thank you to Anne-Marie Cruz for our logos, Eric Vaughn with 17th Street Studios because he provides our music and our recording space. Thanks for listening to our Sleeve Life podcast, where we are breaking that stigma one episode at a time.